and a warm welcome for all of you to the world of echocardiography. I'm Dr. Minu Spandana, clinical cardiologist from Hyderabad, and today I'm here to tell you a few basic views of echocardiography so that you can use in your day-to-day life to deal better with your cardiac patients. This echocardiography, it has evolved in the last decade and it has become very handy so that in our day-to-day life, whoever is dealing with the cardiac patients like the ER physicians or the critical care doctors, intensivists, anesthesia people, general physicians who deal with the cardiac cases, for all this, it has become an extension of physical examination so that we can come to a point, definitive diagnosis, and we can treat the patients better. This echocardiography has evolved so much in the last decade because it is very easy to perform if there is an expertise in this field, and it is a non-invasive method which is live imaging of the heart. It is not only done in the OPDs but also we can do it in unstable patients like in the emergency departments, in OTs, pre-op period, post-op period, ICUs. Whenever we have a doubt whether this particular symptom is of cardiac origin, or whenever we have confusion between whether, like for example, if patient has SOB and difficulty in breathing, it might be due to any reason, like it might be a respiratory cause, a cardiac cause, or a renal cause, or something else. So we can easily rule out whether it is cardiac in origin or not. This is not just a screening test. It gives us the definitive diagnosis if it is cardiac related, and we can do a quick assessment of the patient, come to a definitive diagnosis, and give specific therapy for the patient if it is of cardiac origin. So this will decrease the confusion among the physicians dealing with the patients, and also it gives better prognosis to the patient because quickly we are assessing and giving treatment to the patient. And as this slide tells us a small gist about what is echocardiogram. I'm briefly explaining this slide. Echocardiography, there is a machine which has a transducer. This is the transducer. This is the monitor, and it also has a processor. So we place gel over this transducer and place it on. This is the person who is performing the echo, and this is the patient. This is the echocardiography machine. So we place this transducer with the gel on the patient. There are specific sites where we have to place this transducer so that we can see a clear image of the heart. So these sites are called as windows. We'll be knowing about them in the next slides. So in these windows, whenever we place the transducer, we get live image of the heart. Actually, the mechanism behind this is the electrical energy is converted into ultrasound waves in the transducer. There is something called as piezoelectric crystals in this transducer which convert the electrical energy into ultrasound waves. And these waves travel through the transducer, through the gel, the chest wall, and they travel till they reach the heart. So depending upon the morphology of different structures in the heart, they get reflected. There is a receiver in the transducer itself. The reflected waves, they are caught by this receiver, and they are sent into the computer processor. Here the image is processed and the live heart is seen on the monitor. This is the gist of the mechanism, what happens in an echocardiogram. So I have mentioned about the windows where the transducer has to be placed so that we can see the heart. Wherever in the left side of the chest, wherever we place, we get a view. It is not like that. There are particular points where we have to place the transducer. First is the parasternal window, apical window, subcostal window, and the suprasternal window. Parasternal window is here. We have to place the transducer in the first, second, third, fourth, roughly in the third or fourth intercostal space in the parasternal region. If it is on the left side, it becomes the left parasternal view. If it is on the right side, it becomes the right parasternal view. So parasternal window is in the third, fourth intercostal space in the parasternal region. Next window is the apical window. Apical window is near the apex of the heart. We all know where the apex of the heart is. That is in the fifth intercostal space. This is the fifth intercostal space, just lateral to the midclavicular line. So this is called as the apical window when we place the transducer here. And next is the subcostal window, just below the xiphoid process of the sternum. in the subcostal region below the diaphragm. This is one window. From here also we can see the heart. The next window is the suprasternal window. This is present in the notch of the sternum, that is just above the manubrium sterni. It is present. So there are four major, these are the main windows. There are some other windows which we will know in the advanced course. Parasternal in the parasternal region, apical at the apex, subcostal below the xiphoid process, and suprasternal above the sternum. And the next thing we have to learn is how should the patient be positioned when we are doing a 2D-ECHO. The main position of the patient is the left lateral position. This here you can see. Other is the supine position and supine position with neck extended. All the parasternal views and the apical views are done in the left lateral position. This is the main position. I'll tell in detail in the next slide. This is the left lateral position. This is the apical view the echocardiographer is doing. And the patient has to lie in this left lateral position with his right hand straight and the left arm should be flexed just below the head. This is the parasternal and apical views we can get best in this position, most common position. Next is the subcostal position. The transducer here is placed in the subcostal region just below the xiphoid process, and for this subcostal view the patient should lie in supine position. Okay. The next one is suprasternal position. This is the patient is in supine position only as in subcostal view, but the neck is extended here so that we can get a clear view. And the probe is placed in the suprasternal notch. This is called as a, here we get the suprasternal view, and the extension of the neck is done because whenever it is extended, whatever the great vessels present in this suprasternal region, they are visible clearly. So three positions we have learned. One is the left lateral position for the parasternal and the apical views. One is the supine position for the subcostal view. Supine position with neck extended for the suprasternal view. Next, we have to know a little bit about the imaging planes. There are for every window, there are long axis views and the short axis views. Long axis views, we cut the heart in this sagittal direction so that depending upon the position where we are cutting the heart, we can see the structures. And the short axis views, we are cutting the heart in the transverse direction so that depending upon the place where the section is made, we can view different structures. So these are the two planes, short axis plane and the long axis plane. Coming to the actual views of 2D-ECHO, this is all about the preliminary things you have to know before trying out doing a cardiac echo. First is the parasternal long axis view, very important view because many structures can be seen here. As we already know that parasternal views are got in the parasternal window. So third, fourth, fifth or intercostal space on the left side in the parasternal region is the parasternal long axis view, like this. Third, fourth or fifth intercostal space in the parasternal region, and this is called as the pointer of the transducer. So this pointer should face towards the right shoulder. Patient should be in left lateral position. Transducer in the parasternal window with the pointer pointing towards the right shoulder. This is a left parasternal long axis view. So in this long axis view, we are cutting the heart in this direction. So the structures which are visible, if the heart is cut in the parasternal long axis view, all these structures we can clearly see. Here is our transducer. And this is the 2D image we get it. This picture I have posted here just to understand what are the structures related in this parasternal long axis view. So this is in the parasternal long axis view from anterior to posterior, what are the structures we see. This is RV free wall. This is RV cavity, the interventricular septum, LV cavity, the posterior wall of LV. This is a mitral valve. This is the aortic valve. This is aortic cavity and LA. So this is the 2D image how we get whenever we place the probe. So we can see LA, LA opens into LV through the mitral valve. LV opens into aorta through the aortic valve. Apart from this, we also can see RV. This is intraventricular septum. This is the posterior wall. This white thing which you can see here is echo dense layer. This is the pericardium. So all these structures you can see. Any pathologies in these structures or any functional abnormalities in these structures, you can clearly identify in the view. I will also show you a moving image of the parasternal long axis. The same thing. RVOT, the IVS, LV. This is called the posterior wall or the inferolateral wall. These are the two leaflets of the mitral valve, aortic valve, aorta, LA. Sometimes if we are lucky enough and the view is really good, we also can see the descending aorta here. And there is a small echo-free space. This is the coronary sinus. So this is the parasternal long axis view. Next, in the parasternal long axis view only, there are some RVOT views and RV inflow tract views and RV outflow tract views. We will learn, and generally in our day-to-day life, they are not practiced, but in some places they help us. We will learn in the coming sessions about these views in detail. The next main view for us is the parasternal short axis views. So we have learned about the parasternal long axis view of LV. Next is parasternal short axis views. So the parasternal short axis views, we have to place the probe the same place where we got the long axis view, just tilt the probe 90 degrees clockwise direction, so that now the pointer points towards the left shoulder. Here we are cutting the heart, we are slicing the heart here. Here is the aortic valve, the tricuspid, this is the pulmonary valve, the aortic valve, and the tricuspid valve level. So all these three valves we can see in this view. I'll come in detail in the next views about each particular area. If we see from this view, that is the slice is made at this level, that is at the mitral valve level. This is called as the short axis mitral valve level view, so that we can clearly see the anterior leaflet and the posterior leaflet of the mitral valve, so that we can find out if there is any pathology in the mitral valve. This is at the mitral valve level. If the section is made at the level of the mid-ventricular cavity, this will be the view. It shows us the LV and the RV along with the papillary muscles. This mid-ventricular level is also called as the papillary level view of LV. Next is at the level of the apex. If we make a section and see the heart, this gives us the apical morphology. This is the apical level of LV and RV. So in detail, we will learn about each level of short axis. First one is the parasternal short axis view at the level of aortic valve, tricuspid valve, and the pulmonary valve. So when we make a section at this level, the short axis view of these three valves can be clearly seen. When you see here, this is the aortic valve, this is the tricuspid valve, and this is the pulmonary valve. So what are these structures also we will learn in detail. This is the 2D-ECHO view. In the 2D-ECHO, we can see like this whenever we do this view. This is the left atrium, right atrium. In between, what will be there? Interatrial septum. The right atrium opens into RV through the tricuspid valve. So here, this small structure which we are seeing here is the tricuspid valve. Then RVOT opens into the pulmonary artery. This is the main pulmonary artery, and the pulmonary valve is present here. This center one is the aortic valve. We can clearly see that the aortic valve has three cusps here. So this is at the this is the short axis view, parasternal short axis view at the level of three valves. That is, the tricuspid valve can be seen here, aortic valve, and the pulmonary valve. Any pathologies in these valves can be clearly seen in this particular view. So we should place the probe in the same position. See, this is the morphology. This is a normal morphology. Next is at the level of aortic valve. So this is the short axis view which clearly shows us the aortic valve. Aortic valve has, what are the structures of the aortic valve? It has three cusps, three commissures and an annulus. All these structures can be clearly seen here. This is one cusp, this is one cusp, and this is one cusp. So there are three cusps for the aortic valve, and this is one commissure, this is one commissure, and this is one commissure. Three cusps, three commissures, and this is called as the annulus of the aortic valve. All these structures we can clearly see in this particular view. Any aortic stenosis or aortic regurgitation we can find out in this view. So when is the aortic valve closed in the cardiac cycle? During the diastole. So here it is closed. So this is a diastolic view of the heart, where the aortic valve is closed. Aortic valve opens during the systole. So this is the systolic view. In the systolic view, we have freezed the picture and kept. So aortic valve is opening like this. So even the aortic valve area we can calculate. In short to say, any pathologies or any problems in the aortic valve can be clearly known in this view. This is the aortic level short axis view. This one. Next is the pulmonary artery view. In the same position, we have to just tilt the probe a little bit towards the couch so that we can get this clear view of the pulmonary artery. We should not move the probe here and there. Only just a tilting, angulation of the probe should be done so that all these views can be clearly seen. This is called as the pulmonary artery view because here we can clearly see this is the pulmonary valve. This is the main pulmonary artery, MPA. There are two branches arising from the pulmonary artery. This is the left pulmonary artery and this is the right pulmonary artery. So here, any pathologies in the pulmonary valve like pulmonic stenosis, pulmonic regurgitation, or any congenital defects like pulmonary valve dysplasia, all this we can clearly see in this view. And also any pathologies in the pulmonary artery. What is the most common thing we see in 2D-ECHO and pulmonary artery is an embolus. In pulmonary embolism, if the embolus is there in the main pulmonary artery, we can clearly see. If the embolus is in the proximal parts of right pulmonary artery or the left pulmonary artery, we can clearly see in this view. And also if any PDS are there, patent ductus arteriosus also, we can clearly visualize in this view. So in short to say, this is pulmonary artery view where we see the pulmonary valve, main pulmonary artery through two branches, left and right branches of the pulmonary artery. So next, the same parasternal short axis view, we can, if the person who is doing an echo is an expert in the field, we also can see the coronary arteries arising from the aortic, from here, from the aorta, this coronary arteries arise. This is LMCA, left main coronary artery origin, and this is RCA, right coronary artery origin. So this also we can visualize. So if there is stenosis, that is, if there is stenosis in the very proximal part near the ostia of RCA or LMCA also, with the help of color Doppler, we can clearly see in this view. Next view is the same position. We are just tilting the probe so that we can clearly see the mitral valve. So this is called as parasternal short axis view at the level of mitral. Here we can see the anterior leaflet of the anterior mitral leaflet and the posterior mitral leaflet very clearly. So any pathologies like any congenital defects in the mitral valve or any mitral stenosis or mitral regurgitations, all this can be clearly visualized in this view. And even if there is mitral stenosis, we can calculate the area of the mitral valve also in this view. So that this is by a method called as planimetry. We will come in detail when we study about the valvular pathologies. So in gist of this position is, this is short axis view at the level of mitral valve. so that we can see both the mitral leaflets AML and PML. Any pathologies in the mitral valve can be found in this view. Next is at the level of mid-ventricular cavity. If a section is made so that we are seeing the heart in the mid-ventricular cavity, it will be like this. This is LV and this is the RV. LV we can see it in round shape and RV is seen in the crescent shape. This is the interventricular septum between RV and LV, and this is also called as papillary view of short axis because we can clearly see the papillary muscles which are present in LV. This is the posteromedial papillary muscle and this is the anterolateral papillary. This will be the 2D-ECHO view. This is LV, this is RV, this is the posteromedial papillary muscle and this is anterolateral papillary. So why is this view helpful for us? Here, this view is mainly important for us to see whether there are any regional wall motion abnormalities. So, for example, if the patient is having some anterior wall embolism, so this territory, this is the anterior, all this territory is supplied by LAD. So there is some wall motion abnormality in this area in anterior wall MI patients. So wall motion abnormalities can be detected by this view. In just to say about this view is the mid-ventricular LV short axis view. This is also called as short axis view at the level of papillary muscles. This is mainly used to see whether there are any regional wall motion abnormalities. One thing. And if the RV is dilated also, we can clearly see in this view. These are the two important things which we notice in this view. So this is a diagrammatic representation. This is the LV. This is the anteroseptal wall, anterior wall, anterolateral, infralateral, inferior, and infroseptal. This is RV, which is crescent shape. This is the RV free. Next is at the level of apex. If we make a section, how we can see the LV. This is LV apical region. Here we see only anterior, lateral, inferior, and septal walls for LV. And this is RV. This is RV. At the level of the apex, we are cut. This is also mainly used for, we can clearly see if there are any regional wall motion abnormalities. LV aneurysms also can be detected in this plane or in this view, we can see. So the parasternal long, we have learned the parasternal long axis and the short axis view in detail till now. The structures which are present at the different levels, the pathologies which we can find out at those particular levels. Now coming to apical views. Apical views, we have already learned that we are placing the transducer in the apical region. Apical region is what? Fifth intercostal space on the left side, just lateral to the mid-clavicular line. Wherever the apical impulse is felt, from there we are seeing the heart. This is the position of the transducer. And the pointer should point towards the left side, just lateral to the mid-clavicular line, fifth intercostal space. So here the section is made in this direction, so that the structures we see are this is the four-chamber view. This is called as the apical four-chamber view because here we are able to see all the four chambers of the heart. What are these chambers? This is left atrium. We will see in reverse direction because we are placing the transducer at the apex. From that side, we are seeing the heart. So the lower ones will be the atrium and the upper ones will be ventricles. This is left atrium opening into the left ventricle through the mitral valve. This is right atrium opening into the right ventricle through the tricuspid valve. So in these views, what are the structures we are clearly seeing? Left atrium, left ventricle, right atrium, and the right ventricle. Four chambers and two valves, tricuspid valves and the mitral. This is the interatrial septum. This is the interatrial septum, and this is the interventricular septum. So any pathologies in these two valves like MS, MR, TS, TR, any congenital defects or any other acquired defects can be easily noticed in this view. And also, if any regional wall motion abnormalities are there for LV or RV, also we can clearly see any masses, tumors, or any clots in different regions of the heart. We can clearly see in this view. Okay. Uh, Next view is that was apical 4-chamber, and the same position we should just tilt the probe towards the couch. We get the apical 5-chamber view. All the structures which are there in apical 4-chamber views can be seen here. Apart from this, the fifth structure which we are able to see is the aorta and the aortic valve, the alveoli. Aorta is the fifth structure. So this is called as apical 5-chamber view. The 4 chambers, the 2 valves. Apart from these 2 valves, aortic valve is also seen. The alveoli is also seen. So here, whatever we can diagnose in the apical 4-chamber view, the same things can be diagnosed in apical 5-chamber view. Apart from that, extra what we can see is any alveoli obstruction, any aortic pathologies, any aortic valve pathologies like infective endocarditis of the aortic valve, or aortic stenosis, or aortic regurgitations. All these can be clearly seen in this view. So this is the apical 5-chamber. Next is apical 2-chamber. The transducer in the 5-chamber view, we have pointed it towards the left. Now we are tilting the, we are rotating the probe. We are rotating the probe in anti-clockwise direction, about 30 to 40 degrees. We get this apical 2-chamber. Here, 2-chamber means only 2 chambers we can see here. That is left-sided chambers we can see. What are the left-sided chambers? Left atrium and the left ventricle. The valve between them is mitral valve. So it is very easy. Apical 2-chamber view consists of left atrium, left ventricle, and the valve in between them. That is the mitral valve. Any pathologies in these 3 structures can be clearly noticed in this view. And also the walls which we see are inferior wall of LV, apex of LV, and the anterior wall of LV. So any regional wall motion abnormalities in these walls also we can clearly see in this view. Next view, this is the apical 2-chamber view. Sometimes we also, if the view is very clear, we also can see the descending aorta. So any descending aortic aneurysms are there, or any aortic dissections in the descending aorta are there, we can view in this apical 2-chamber view. And also in the apical 2-chamber view, we also get to see the left atrial appendage. This projected part, this is the left atrium. So this projected part is the left atrial appendage. When is this useful for us? Whenever there are any clots in the left atrial appendage, like in cases of mitral stenosis, aortic fibrillation cases, this view is very important to see whether there is any clot, whether we have to start anticoagulation to the patient or not. We can decide depending upon this view. Okay. So this is the apical 2-chamber view. Next is apical 3-chamber view, or the apical long axis view. From the 2-chamber view, the probe has to be rotated anti-clockwise, again 30 degrees from that position. Then we get the apical long axis view. And this apical long axis view is also called as the apical 3-chamber. Here LA, LB, aortic valves which are present in the apical 2-chamber view are seen. Extra thing which we see is this is the mitral valve, sorry. And the LVOT, aortic valve, and the aorta. That is the inflow of LV, outflow of LV, or all these structures can be clearly seen in the apical long axis. So what we have learned in the apical views, what are the different views? One is 4-chamber view, which we see the 4 chambers. Next is the 5-chamber views, where aorta is added extra to the 4-chamber view. Then the 2-chamber view, which shows us the LA and LV and the mitral valve. This is the 3-chamber view, or apical long axis view, where we see the 2 chambers. Along with that, we also see the LVOT, aortic valve, and the aorta. Okay. So any pathologies in these structures can be clearly noticed in these views. This is about the apical views. Now coming to the subcostal window, where we have to place the probe in the subcostal window. The probe is placed in the subcostal window, that is the xiphi-sternum in the subcostal region below the xiphoid process of the sternum. This view is mainly important in children. In children, we can very beautifully and clearly see the subcostal view, which rules out many congenital diseases. And in COPD patients, the normal views which we see, which we have learned till now, they are not very clear because of the pathology in the lungs. So in such patients, the subcostal view is very good. But the only difficulty with this view is the patient is very obese. Because of the fat, we cannot see very clearly the subcostal window. And we have to place the transducer like this to see the subcostal view, 4-chamber subcostal view. The pointer should face towards the left side of the patient. The patient position we have already learned for subcostal view, that is the patient should lie in supine position. So supine position, transducer in the subcostal window with the pointer pointing towards the left side. We get a 4-chamber view here. So this is the view which we get when we put the probe in the subcostal region in the position which I have explained. So these are the 4 chambers. It is similar to the apical view, but from a different direction we are seeing the heart. So the 4 chambers are LA and LV, RA and RV, the 2 valves, that is the mitral valve and the pulse. Any pathologies in these structures can be clearly identified here. There are also subcostal short axis views. They are more important in diagnosing the congenital heart diseases in children. Basically, these views are very important. We will learn in detail about this subcostal short axis views in the coming lectures. This is the main thing which we have to learn. Subcostal view with 4 chambers. And another thing which we use in our day-to-day life in the subcostal view is about the IVC. Generally, we get cardiologists get calls from the ER or they get calls from different ICUs to see the volume status of the patient. We have to measure the IVC and we can assess the volume status of the patient, whether to give fluids or stop fluids. So this subcostal view is very important to see the IVC, and hemodynamic monitoring of the patient can be done with this view. So here in the subcostal region only the probe should be placed with this pointer pointing towards the neck of the patient. So this is called as the subcostal great vessel view, which shows us IVC. For the IVC, what is the important view means? We should write subcostal great vessel view. The patient lies in the supine position, the probe in the subcostal region with the pointer pointing towards the neck. So what are the things we can see in this view? Mainly it is the IVC. IVC, where it opens into right atrium. So this structure is right atrium. IVC always opens into right atrium. IVC, right atrium, and what opens into the IVC? Hepatic veins. So these are the hepatic veins which open into the IVC. We can clearly see the hepatic veins, the IVC opening into right atrium. So it's a very big chapter to explain how we assess IVC and all. In the coming classes, we are going to clearly learn about how to evaluate the patient for the volume status. So this is just a basic thing. The view should be like this. How to get the view for IVC is this slide show. So this is the IVC. This is the hepatic vessels, hepatic veins opening into IVC, and this is right. All these things we get in the subcostal view. Next, the last important view is suprasternal view. The name itself tells. Suprasternal view means above the sternum we have to place the probe. We learned in the first slide that where the probe should be placed in the suprasternal notch. The window is present just above the manubrium sternum in the suprasternal notch. This is also called as great vessel view of the heart. Here we see the great vessels of the heart. What are the important great vessels of the heart? The aorta, pulmonary. So these structures can be clearly seen in this view. Depending on the position of the markers, we can see different structures present here. The cut section is from different directions, but the most important view in suprasternal view is the long axis view. What are the structures we see in the long axis? Long axis view, we see the long axis view of the aorta. If the aorta is cut in long axis direction. That is the whole length of aorta. The ascending aorta, arch of aorta, and the descending aorta. All these structures are seen in the suprasternal notch region, and this is called a suprasternal long axis view. So we can see the aortic ascending aorta, arch of aorta, and the descending aorta. Here, transverse section of the right pulmonary artery also can be seen in this view. And this vessel, which is arising from the aortic arch, is the left common carotid vessel, and here will be the left subclavian vessel. So any pathologies in these regions can be identified in this view. So what are the common pathologies we see here? Ascending aorta, arch, and descending aorta. Is dissections of the aorta can be seen, identified, or aneurysms of the aorta can be identified. Any coarctations of the aorta also can be identified in this view. Apart from this, from that, if any patent ductus arteriosus is present, we can see almost in this area by using a colorography. Any stenosis in the left common carotid proximal part or the left subclavian proximal part also can be clearly identified in this view. So there are some, this is the view when we do a live 2D. This is the view. Ascending aorta, arch of aorta, descending aorta. This is the left common carotid, left subclavian. So this is the main suprasternal view which we have to know. There are also some other suprasternal views. We will learn them in the advanced classes of echocardiography. This is called as a short axis view, but generally in our day-to-day life we don't use this view. But having knowledge is very important because in the exams you can get some theory questions about this. This is called as short axis view of suprasternal view. So today what we have learned, what is echocardiography, what are the windows of echocardiography, where we have to place the transducer so that we get different views. What are the different views we learned? Parasternal long axis view, parasternal short axis view, then the apical views, 4-chamber apical view, the 3-chamber view, 2-chamber view, 5-chamber apical view, then the subcostal view, the long axis and the short axis of the subcostal, and the suprasternal views. There are 2 suprasternal views, long axis view and the short axis. So here we have come to the end of the session, and hope you all are happy. If you have any doubts or queries, you can message me so that I can clear your doubts. I hope all you understood, and I welcome you to the world of echocardiography. Try practice. Learning, it looks very easy, but when we practice it, we come across different difficulties. But definitely, if you go on practicing it at least in 4 to 5 patients every day, definitely you will be able to learn echocardiography very easily. It all depends upon your interest and practice. So I'm signing off, and thank you. Hope this class was useful to you.